Let's get close, but not so close. Quarantine. You can share from a distance. Quarantine. You know we want to see each other. You'll have to stay in your quarantine space while we talk.
Today on Quarantine, a deep dive into the facts, revisiting the health numbers and the economy over 3 months after we started here with Quarantine, 3 months into this pandemic. Today, we're going to visit with Dr. Amit Mehta, who is a physician on the front lines in San Antonio, Texas, at a medical center that sees about 2,000 new cases a day. What's it like on the front line? And what are the surprising results of how treatments are improving and what they're doing? We'll also talk about innovations in healthcare that Dr. Mehta is seeing as he invests in and works as a venture capitalist on our nation's medical futures. And then, to get a sense for where health policy is going in this nation, we'll return to a conversation we had on April 1st with Susan Dentzer at the Duke-Margolis Health Policy Center. Susan talked to us about remote medicine and about the policy challenges in COVID. She just finished running a nationwide conference of health policy leaders. She'll give us the report card on how America's doing, what we can expect, and also what might happen in terms of policy changes with remote medicine and making our health system more effective. Then we'll be joined by Marco Annunziata, who was the former chief economist at General Electric. He also joined us on our episode on April 1st as he was thinking through, well, if the economy opened by June, it might not be so bad. And yet it turned out a little bit differently. So we'll talk to Marco about where we can think the economy might be going and decisions we have to make. Today, a serious re-examination of where we've been and where we're going. And my partner for the broadcast, here's Mickey McManus. Mickey. Hi there.
Hey, Peter. How you doing?
Is your mic on? We never start this show with your microphone on. So
it is on.
Yeah,
can you hear me?
Great.
Yeah, I know.
Yeah. So we thought it would make a lot of sense to revisit two of our guests from, I think it was our fourth show.
Yeah, episode 4. It was April 1st. And the curious question was, it was about sort of the two different parts of uncertainty, economic and health uncertainty. And actually, if we can go to the whiteboard, because we've been kind of capturing, here's the whiteboard. I just zoomed back in time to our time capsule. And at one point, Peter and Marco took a look at this video clip that was from Italy. And it was a very powerful kind of moment where people were just yelling on the street. It looked like society was breaking down. And Marco was able to tell us, actually, no, this is only one part of Italy, but it's certainly a big signal, because they were basically yelling for help from the standpoint of money and things like that. And the question was, is Italy, this was April 1st, 10 days ahead of us? In other words, what we were watching in another country, something we could expect. And I think now, looking back, that looks adorable almost, that we would worry that we would look like that. But in reality, it's a lot of time has passed. A lot of things have happened. And Susan shared a little bit about telehealth. And, if we get the assumptions right or wrong, do we understand the assumptions? And, here we are in April, would we be able to restart the economy in June? And that was part of the question. And Marco and Susan both were talking about this kind of balance that we had between the health uncertainty and the economic uncertainty. And it feels like revisiting that conversation now, because clearly COVID is kind of out of control in many other states of the country. A lot of the things we said, if we only had, a lot of testing for serological testing and testing for the actual, the COVID virus itself during infection, we would know. We hope we could get there by June, and now let's revisit that. So I'm super excited to have both Susan and Marco back, and we'll mix it up and we'll find out what the bottom line and the front line looks like, both with Amit and Susan on the telehealth and healthcare side, and with Marco on the economic side.
Before we go off to Amit in Texas, let's say hey to Marco, who's joining us. Hey, Marco.
Hey, Peter. Hey, Mick.
Hi. Look, we're thrilled you're here. This is kind of the first time we've done this retrospective. We've known from the start when we did Quarantine that this has become a little bit of a time capsule because we're recording things twice a week. So give us a little preview. How surprised are you with how things have developed? And are economists converging on what to do, or are our fights breaking out in your field?
Economists never converge on what to do, and this time is no exception. I think there is a little bit of convergence on the fact that the government help is still needed. From my perspective, I've been surprised by how responsive and ready to bounce back the economy seems to be. And secondly, I've been surprised by how little we seem to have improved in the public discussion on this trade-off between economic uncertainty and health uncertainty that we discussed last time. Those for me are the two major surprises. One is positive, one a lot less so.
Yeah. I mean, why don't we put up this slide for a little bit later in the show? I've put together a lightning round of some headlines. This was an interesting one the other day. Bloomberg did an interview with Nouriel Roubini and Joseph Stiglitz. And Roubini, of course, as Dr. Doom, had this view that, look, there's going to be bankruptcies, consumer confidence will be down, spending will be down, there'll be a bounce up, and then there'll be inflation in a very dark time. And Stiglitz says it'll be great if there's government intervention, but it won't be American capitalism as it's been. It'll be something new. I invited you to give us your thoughts on that, and evidently your conclusion is you don't like either of those guys.
I dislike them both for different reasons. I mean, they're two extremely smart guys, extremely good economists. However, in the case of Roubini, what I don't like is that smart as he is, he's become very enamored of his position as Dr. Doom.
Yeah.
And he's made a name for himself, but I'll give you two thoughts. One is that they've actually calculated that if, when he first started warning about the famous global financial crisis, if then you had sold your stocks and said, okay, I'm out of here, doom is coming, you would have been worse off, lost money, compared to holding on to your stock portfolio all the way into the global financial crisis, absorbing all those losses, because you would have lost such a major upswing in such a long period of time before the crisis came. Second example, 2012 or 2013, Nouriel Roubini on Bloomberg Television asked, do you think we might have a second recession in the US? And he confidently states, we are already in a second recession. And the second recession never came. It would have come in 2030 if it had not been for COVID-19. So that's my problem with Nouriel. With Joe Stiglitz, I think he's supremely smart, and when he talks about the need to rethink capitalism as we have it right now, he has a point. My worry is that he tends to point to Europe as an example of how we should do it. And let's remember that, yes, Europe seems to be managing better the surge in unemployment right now, but Europe on a permanent basis has unemployment running between 7 and 10% at the best of times. We in the US were unhappy with unemployment at 3%. So before we take that as the exact model, I think we should think twice.
This is a great taste of what's to come in the great economic food fight we are about to have in the second half of the show. For now, let's kick it off by going to Dr. Amit Mehta. Amit is a physician. He's a radiologist in Texas, but he's also a medical entrepreneur, and he's a partner with Builders VC, which is a firm that has a large healthcare investment. So he has one foot in as a practitioner and another in investing and creating companies that are poised to take advantage of where healthcare is going. We visited him to really get a sense for what it was like on the front line. And when we visited him, we actually recorded this late last night because during the day, he is in complete protective gear, doing all sorts of imaging and radiology in San Antonio. So let's go to Dr. Mehta for the Frontline Report. welcome to Quarantine. We're with Dr. Amit Mehta, who is in the front lines of healthcare in Texas. And you are also an entrepreneur and inventor and investor in this space. Why don't you start with a little bit about your background and the work you're doing now, and then we can get into what that frontline experience is like and where we see healthcare being changed in real time.
Sure. Thanks for having me. My background is focused around healthcare. I'm an interventional radiologist, what I do on a day-to-day basis. I have a clinical practice, and for those who are not familiar with that, we do minimally invasive image-guided surgery. So move wires, tubes, robots through the body through very small incisions using imaging as a guidance. So you don't have to get cut open for a surgery, and the recovery is usually hours to days rather than weeks to months. So that was my classic initial training. As I was going through training, I had a significant amount of exposure to novel medical devices, new therapies. It was a field that was on the cutting edge of developing things like stents and things like embolic materials. And now where I spend a third of my time is with Builders VC, which is our third fund. We're a classic Series A shop, Silicon Valley firm, where about a quarter of our first fund, we're now raising our second fund, but the quarter of the first $200 million fund went into healthcare, and primarily healthcare IT. So it was an exposure to a significant amount of healthcare IT and shaping healthcare practice around what I was seeing on the front lines as a practicing physician, and the break points in the healthcare system, and having an opportunity as an investor to say, these are the things that will be impactful for the healthcare system, and at the same time be given ROI to something like a venture fund.
Right now you're also a practitioner. And when I checked in with you earlier, you sent me a picture. You were in full COVID bio gear, and you said, "Can we talk tonight after we get done with COVID?" You're in San Antonio. What is it? Kind of give us a description of kind of what days are like now, and what the pace or what you're seeing in terms of how this is evolving.
Yeah, I mean, days here. We're in a center that has over the weekend had 1,300 cases on Saturday, 2,000 cases Sunday. It's been a crazy, crazy time. It's long, it's exhausting, and it's draining emotionally and physically. These are full. I posted a couple of times on social media and LinkedIn these things where when I read these things on social media where people say this thing's a hoax, or why do you have to wear a mask, or why do you have to social distance? I had a patient last week where a young man, 22, he was telling me, he goes, "Look, I used to make fun of people wearing masks, and this is dumb." And then his father was in the ICU, and his father passed away. And he said, now it's real to me. And he's out there now proselytizing, telling people, you need to wear a mask and social distance. So our ICUs are almost at capacity. There is room, a little bit more room, but it's exhausting. I mean, every patient has COVID. For us in imaging, every imaging study, every patient that we do surgery on has COVID. So we're donning full PPE gear.
What is an example of what you're doing with imaging? From a interventional radiologist, like, what's your day look like?
So I spend about 50% of my day in an operating room doing minimally invasive surgery. So a lot of these patients, we're learning a lot, right? I mean, at the beginning of this, we didn't understand anything about this virus, and we're learning now that patients with comorbidities, ethnicity, all of these things play into the severity of disease. So these patients are really sick in terms of not only respiratory capacity and respiratory issues, but other systemic organ problems. And with those organs failing, there's always need for the things that we do. So a lot of that for COVID patients is maintenance therapy. And then on the imaging side, just constant, in the hospital setting, drop in blood pressure, is it, are they bleeding somewhere? Is it change in mental status? They get an MRI of the brain. Their O2 saturation drops. They get a CAT scan of their lungs. I mean, every single
Yeah.
organ system is
This
affected
is
by
every
this
kind of
virus.
imaging imaginable. It's MRI, it's ultrasound, it's CAT scan, it's various kinds of things, and you're trying to see what the heck's happening. And I guess you've learned a lot in the last few months about the lungs and about what's happening with people having to go on dialysis when it gets pretty serious. My father died from COVID, and we had an episode about that in Chicago, and he was actually doing pretty well, and then suddenly he tanked. He didn't have COVID when he went in the hospital, but by the time he passed away, he had COVID. So what are the kinds of things you're seeing? I mean, he had to be put on dialysis intubated and actually ultimately on a breather to help him. What are the kinds of things you're seeing what are the new learnings, I guess, you're making out there because we've got a few months under our belt?
I think, we're seeing a lot. So obviously the respiratory issues are paramount, right? I mean, we're seeing multifocal pneumonias with the virus and then superimposed infections. So respiratory issues. And we've learned sort of putting patients on respiratory ventilators very quickly. Obviously doesn't sometimes work. It's not a good idea. Treatment. Yeah. One thing that what we do here, which we're really strong on, is a program called ECMO, which stands for extracorporeal membrane oxygenation, which traditionally was used in babies, but basically a patient is hooked up with large bore tubes, typically one in the artery, one in the vein, and then all of the blood is then, like dialysis, passed outside the patient, oxygenated, and then put back in. And so you can give the heart and lungs a rest by doing that, and that has been revolutionary in saving some of these patients who otherwise would die. And not all places in the country have access to ECMO.
The ability to do that. Yeah.
It's a specialty treatment. So we're seeing a lot of patients being put on ECMO, and it's working for salvage patients who are close to death. And those are the patients it works well on. And we're learning, I think, a lot better how to triage patients now. If you come in and are asymptomatic, obviously you go home and quarantine. If you have a fever, we ask you to go home. We have a telemedicine program where you come into the ER and you test COVID positive, low-grade fever, but your O2 saturation is higher than 95 or a certain number. We send you home, and you have a telehealth visit every day with remote monitoring. And then if you become sick where your remote monitoring numbers qualify you, then we bring you back in the hospital to preserve beds. So
do you end up sending anything home with them? Do you end up having some other ways of doing telemetry when they're at home, or is it more checking in? In other words, are you sending devices home with them?
Basic things like pulse oximeters at people's homes.
The program itself, this has all come on so quickly, right? And as with everything in healthcare, it has to be typically validated 11 times before you can give anything to anybody. And so there hasn't been enough time to validate a specific touchless thermometer or a specific pulse oximeter. So what's happening is, and we've done this, my family has done this, we bought our own touchless thermometer and our own pulse oximeter, and we use it as a monitor. It's a guide. It's not considered to be a diagnostic device by a physician. So they're not billing for the remote services, for example, but it's more of a check-in. And people are told, get a touchless thermometer and get a pulse oximeter and take your temperature every day. Okay. Whether
if you start to see some trending, it gives you some indication, like get the heck back into the hospital. Well, that sounds like it keeps a lot of people at least safely away from places that they might get they might have more challenges until you can bring them in. It also helps you flatten the curve there. What are some of the surprises that you've seen, in terms of what you're learning?
I think the biggest surprise recently has been this second wave of younger folks and learning who gets this virus and who gets really sick. That was we're seeing in the Hispanic and Black populations, there's mortality is much higher, 25, 30, 40%, as opposed to in the non-population is less than 1%. So healthy.
Wow. And is that because those populations were less healthy or obese or something, or is it?
Yeah, it's the comorbidities of diabetes, hypertension, obesity, and it's the comorbidities that get you really sick. So
can you explain comorbidity just for our viewers? You know, just so that might be a kind of a medical term, but
sure, yeah, it's just
common words.
Yeah, absolutely. It's the presence of, they teach you that in medical school when you're with your patients, right? Like, don't use big words like, oh, sir, you have tracheobronchoosteopathica. You try to break it down so that you have something in your throat. Yeah.
Yeah.
So I apologize. Yeah, comorbidities just is having adjunct or simultaneous disease processes. So if you're diabetic and you're obese, then those things are things that cause decrease in your health. So morbidity versus mortality, which is mortality is death, morbidity is ill health, so to speak. So a comorbidity is another condition that you may have, a chronic illness that then contributes in a multifactorial way to the primary illness. And so if you don't have comorbidity, and a lot of this is anecdotal, has not been published yet. I think it's coming out now, but what we're finding when you look at, when we're treating these patients, the patients that we see that are really sick fall into these categories.
Another question is that this disease has been something of a mystery, its mechanisms and exactly what it's doing. And I think maybe this is what leads to some of the mischievous posts where people don't understand it, or it seems to take a change. For example, I've read things where it seems to do interesting things to blood platelets, and is it doing interesting things to the blood that may be the thing that explains or unifies why people get strokes or why they get heart attacks? Are the things that we're learning about its mechanism that are confounding but begin to help put together a theory of the case?
Yeah, I think, that is absolutely true. And, I saw a patient today was med flighted on a helicopter we're a tertiary care center from an outside hospital, was at home, collapsed, came in, had some preliminary imaging. They determined he had a stroke, and both his carotid arteries, which are the two big blood vessels that supply the brain, had thrombosed or clotted off. And like you just said, there's a platelet disorder. So he had, he tested COVID positive, had COVID in his lungs, and obviously was had the virus and had become what we call hypercoagulable, or having the blood, it becomes more prone to clotting, and both his big arteries coming to the head and clotted off. And if he'd known that, he would have been on either antiplatelet or anticoagulative therapy. So if you're in the hospital with COVID, we anticoagulate the blood just because that is a known thing now. But we're seeing that as one of the effects of the virus, amongst a few other things. But
now you just said some other words there that I want to just be clear for our viewers. So you mentioned tertiary care. I have no idea what that means, and I feel dumb. So what's a tertiary care facility? What is it?
So colloquially, hospitals or healthcare centers are categorized as primary care, where you would go if you had a cough or cold, your primary care physician or a primary clinic. Then it goes secondary, tertiary, quaternary. Quaternary would be to the extent where it's a specialty center that if you had a specific disease like rheumatoid arthritis, that it is a center of excellence.
And there's a specialized place for that.
Yeah, 4 in the country, for example.
And tertiary, what does that mean? Are you explicitly dealing with people that we haven't been able to figure out from a COVID standpoint, and you have to go deeper?
Yeah, tertiary typically means it's a referral center. So, for example, in San Antonio, where we are physically, we're a referral center for basically a lot of Mexico. Mexico drains into South Texas. So a lot of our patients are Mexican nationals who will seek a higher level of care. And that higher level of care is in a tertiary center, which means we have all of the specialties represented. So, anything from neurosurgery to orthopedic surgery to interventional radiology to the specialties that a primary care or a secondary care clinic is not going to have a neurosurgeon. They're just, it's all of that kind of work is centered to a center of excellence.
I'm curious, before we go on to kind of what you're investing in, because I think it's actually interesting to look at what you're seeing in terms of the acceleration of potential new ways of doing things. Before we go there, I'm curious about what is pissing you off. What is just getting you so pissed off about either the way your state, your government, the world, the social media? What is pissing you off about what's happening right now?
I mean, the biggest thing, I was listening to the radio coming home tonight and over the weekend, people are partying in Michigan. People are partying in the Ozarks.
Yeah.
I'm working 12, 15-hour days taking care of these people that have gotten COVID, and then these people are out there partying, completely ignoring all this, right? I say this this is really bad, but I say this to my wife sometimes, like, just wish some of them would get it so they could feel the pain, It's not,
and
it's
we
not
don't
the
want
right
that
thing
to
to say,
happen, but it's a weird thing. It's like when we fought World War II or something, like, we had to actually go and fight. Here, we're asking you to, like, put on a mask, a piece of fabric, and, like, don't hang out at a bar or something. And that's too much, apparently. Like, that's it. Like, we're asking almost too much. And that's disturbing. What hope do you see? What on the other side? What are you excited about just in your own practice, or what you're discovering, or what your teams are discovering about either disease or kind of how to actually take care of people?
I think now that we're getting a handle on this, I mean, we're seeing a lot more people discharged from the hospital. I mean, you see these videos again on social media, people, who were on a ventilator for 30, 40 days now walking out of the hospital. So
and they're celebrating.
we have a host of folks right now ready to be discharged into a step-down facility or a kind of a rehab center who've made it,
What's that feel like for you?
I mean, that's kind of why we do what we do, right? Is for those kinds of stories, and sometimes it is very emotional to watch the people who we've gotten to know just from day-to-day work, because they're we're interacting with them, not in a great way on a day-to-day basis, and
they're human. You get to see them like N=1. You get to see a real person, not some statistic.
There's videos and testimonials and podcasts all over the place of people on the front lines who are dealing with this stuff, who are telling you it's bad. Like, if you get it, it's bad. Like, just listen to them.
Right, and that's another key point. So often people are fixated on, look, the death rate is just this. But one of the things I think that we're learning is this has all sorts of ongoing effects in terms of how it affects your lungs or how long it takes to get better. Richard Quest on CNN talks about the fact that he has it and it keeps coming, right when you think you lick it, it seems to be going away. So this is kind of serious in many cases, right?
Absolutely. Yeah. I mean, I think that's interesting you say that. I mean, it's almost binary to a certain extent. If there's young people who you get it, they're asymptomatic, you never know, and they're spreaders. And then there's folks who get it who are wiped out in the ICU for 30 days. And there's very little in between. I think there's a bunch of people who you kind of feel unwell for a couple of days. You're not sure you get it, but then you can't really get a test, so you don't get a test, and then you wait, and then later you'll get a test. You get an antibody test versus an antigen test, and you say, "Oh, you have the antibodies," which means, you know what? When I had that sort of little bit of malaise a few weeks ago, it looks like I had COVID. So it's so strange, right? I mean,
it is a weird thing. I will notice that I have close associates and family members who are like 16 or 20, 22, 25. And they have a little bit of a Karen attitude. Like everybody older than about 22 is a Karen, if they're female, who have in a sense been weaponized. The same way that Karen was weaponized, 10 years ago against every single black person, or certainly black man. They're being weaponized in another way. It's interesting because I talked to some people who are in their early 20s, and they're like, yeah, we might lose some 60 or 70 or 80 or 90-year-olds. They're not doing much on TikTok, so I'm not sure I see them. And of course this disturbs me because, as I said, we did an episode on grief and ritual because my father passed away, and it was COVID. It was clearly he got it in the hospital, and yet there is an attitude, I think, a generationalist attitude. Absolutely. That you don't quite know what life is going to be like when you get to be a little older. And so it's easy to be dismissive, it seems. And yet, you in the healthcare world, you're in it every day. You're seeing it. Doesn't matter the age. You're seeing it.
Hey,
Yeah,
one more.
this
What would you
22-year-old
say
who's
to
bothered them.
a 16-year-old? What would you say to a 20-year-old?
Well,
Like,
that's
why
interesting.
should they care?
This 22-year-old I was talking about, whose father passed away, brought it home for me. That I was hitting a low there, seeing all this stuff in the media about people not caring about it, and then I met him and listened to him and his story, and that really gave me the energy to keep going. If there was hope, yes, it took a catastrophic event for him to change his mind, but he really did change his viewpoint, not only on this, but on a lot of things as I was talking to him about how he sees the world and how he needs to, keep his eyes open and his ears open more and listen to what's going on and be more mindful of the things around him and stop ignoring a lot of the things because he knows better. 22.
Perfect. Yeah. So
at that age,
he had a pretty much life-changing experience.
Yes.
So tell me a little bit about what's happening with your startups, with things you're investing in. Like you mentioned your fund.
I mean, our focus as a fund is to revolutionize antiquated industries. So we look to invest in industries that are large, where processes are largely paper, pen, Excel spreadsheets kind of thing. Yeah. And healthcare is one of those huge industries. Yeah. Everything's so antiquated. We look at things, it takes eons to implement new technologies. Now there's been big moves with High Tech Act and a lot of the things that are going on in medicine, but to us that's a definitely an opportunity for success.
Do you think that this is accelerating some of the work you're doing with the investments? Do you see that people are like realizing, oh crap, this is antiquated and we need to transform? What are you seeing in that regard?
I think we sort of I went through 3 phases of thinking. At the beginning of this, it was, this is just a virus, this is just another illness like the flu, whatever, and business as usual, we'll just take care of them and then in the middle there we're sort of like, whoa, this is an opportunity for significant change. The world is changing, this is impacting everybody everywhere, and this is an opportunity to look at technologies that can be implemented now and then will be lasting, and telemedicine, telehealth is a good example. I think we're moving into we then moved into and I think we're in a phase now where we're just still trying to keep up. I mean, this flattening the curve. While we'd love to think about using IoT and remote sensing and telehealth, I mean, we're just still trying to take care of the people in the hospital because they're so sick that we haven't had a lot of time to think about that as someone who's on both sides of that equation.
You've thought a lot about, with some of your investments, remote healthcare and clinics that aren't the hospital and pushing care to the edge. Must be a factor here because you want as few people flooding into the hospital and more testing taking place closer to the edge. Can you talk a little bit about that?
Yeah, absolutely. Yeah. I mean, I'm a big believer in that in the future, the locus of care will not be around a hospital, but would be around the patient, personalized medicine at the point of home. And to enable that, we need to see, and we're seeing point of care services such as telehealth, telemedicine, remote monitoring. We've made investments in hardware companies that monitor or sensors that will on an ongoing basis monitor your blood pressure, your heart rate, your ECG, all of these things that instead of having episodic care where you wait till you get sick and then you go into a hospital, which is an expensive event, you're basically maintaining the engine 24/7 with remote monitoring up to a point where you can detect disease before it happens. So preventative medicine, wellness, but all done outside the hospital setting. The hospital then becomes basically, like we talked about before, a tertiary care center that once you need something that only a hospital can provide, then you go to that point of care. And so there's a set of tools in front of that, including the home delivery, and then clinics, whether they're urgent care, primary care, ER clinics, whatever those second line of defense. If you have a cough or a cold, you don't need a $4,000 or $5,000 visit at a hospital ER. If you have a stroke, well, then you need to go to a hospital because you need interventional thrombolytic therapy. So right now, everybody when they get sick typically will go to the hospital ER. That's if you can't get, you call your primary care doctor. They have, the waiting list is 6 months.
So long. Yeah,
too long.
right.
So you can't go there. And I mean, that's a little bit of an exaggeration, but typically it's a long wait. So you're not going to your primary care, so you're going to go to an ER. And before there was outpatient ERs, you would just go to the hospital, and the hospital gets inundated. And the system is set up that, from a reimbursement perspective, that works, right? I mean, the insurance companies pay for it, the hospitals get paid, the physicians get paid, everyone gets paid. And I think this is where the genesis of our original conversation was around, telehealth, telemedicine. In the time of COVID, the government did come out. And so the government previously, for telemedicine specifically, which is remote care, remote consultation from physician to patient or nurse practitioner to patient, whatever care provider was only typically in rural areas that they would reimburse. So if you were in a metropolitan area and you wanted to get a telemedicine visit, it wasn't something that the government would necessarily reimburse. And even then, the reimbursement rules were very difficult, and there was legislative stuff around licensing and this, and typically they would reimburse at an 80% rate and the patient would cover 20%. All of those rules have been relaxed in this time of COVID and said, you can't come in, so all telehealth visits the government will reimburse at the full rate. And I can tell you, a lot of folks, a lot of my colleagues, partners who do a lot of telemedicine have said this is the best thing. I mean, they're not using it specifically for first-time visits. It doesn't make sense. If you need to do a physical exam, listen to lungs, those kinds of things, you can't do it. But if you're a chronic diabetic or rheumatoid arthritis patient and you're having your follow-up visits, there's really no reason you have to come in most of the time. I mean, it's a maintenance visit to make sure that you're not having any problems, that kind of thing. It's perfect for telemedicine. And it's made these offices, A, very efficient, B, the patients love it, and C, it's better for the system because it's not.
I think that the patients are getting so acclimated, I mean, at a very large rate, like a huge population are getting used to a Zoom call or a telemedicine call. Do you think that that's going to get put back in the box after COVID?
Yeah, from an idealistic standpoint, absolutely, it should stick, and it's a better system. It's better for everybody. The reality of it is, I think the financial incentives are going to drive a lot of persistent adoption, because a lot of the system and the clinics are built around, the performers are built around seeing X number of patients over X Y period of time to pay your nurse practitioner, your secretary, your biller. The economics are at the end of it. So I think if the government retracts the reimbursement rates, and then all commercial payers typically in the US will follow government payers in terms of how stuff works. I mean, Medicare, Medicaid is the driver of what the rates are. Commercial payers typically pay multiple, whether it's less or more, but it's centered around Medicare. So if the government does pull that back, then I think a lot of the telemedicine will pull back as well.
So watching Medicare, Medicaid, and how the government does that or even the VA, how they do that for the people they have to fund,
correct,
is going to probably be a signal for commercial.
Absolutely.
Ventures.
But as an entrepreneur looking at this, you're probably seeing efficiencies. Like, in other words, from a legacy perspective, a medical complex that's built around the fixed costs of people coming in might be unhappy at not getting its overhead paid from the visit. Investing in something new, we're probably learning something about efficiency or the types of cases that can be handled in a teleway. So do you imagine that makes the case for new kinds of services that ultimately the government gets excited because the reimbursement, it's less cost for more effective? I mean, do we see that kind of stuff coming out of what we're learning from this?
Yeah, absolutely. And that's what we're looking for, right? Is that if the reimbursement is 80%, run at a 50% efficiency of cost. So before you were running at 70%, there's a 30% margin. You can still maintain that 30% margin from 80 to 50. I mean, that's what we're looking for, is technologies that will enable that to happen, because the impetus and the drive is for everyone who wants to do telemedicine. From the physician standpoint, from the office perspective, from the patient's perspective, everybody wants it. So if you can make it work, everybody will use it and continue to use it.
It's rewarded. Yeah.
Right.
Yeah.
And the gift right now is that they're reimbursing at the 100%. So if you're an entrepreneur or a forward-thinking physician or provider, you can use this opportunity to put those systems in place while you're at 100% reimbursement that when and if the reimbursement goes back down, you become that much more efficient. So you have a period of time where that margin and that efficiency has allowed you to implement the infrastructure to do this, that when the reimbursement goes down, you can maintain the margin.
So it's kind of almost like at this moment, these innovators could spin up the flywheel, could get it spinning, such that when something retracts a little bit, they've already got momentum. They've got people excited. They got people who see the value, and they're demanded almost.
Absolutely.
There must be a bunch of healthcare economists who are all over this stuff and fascinated by what's basically a natural experiment and a whole bunch of prototyping and A/B testing going on.
You would think that. I haven't seen it. What's interesting and what I tell my partners is that we've talked a lot about why I still maintain a clinical practice as an investor, and why I just become a VC, right? Is that day-to-day being in the trenches and understanding not only the movements of patients and clinical care, but reimbursement and all the pieces that go into a medical practice.
Yeah, I think you see the skin. You have skin in the game. You see what actually happens. And that seems valuable. Yeah,
and it's a secret weapon for me, in that if I can look at my friends, my partners, my colleagues who are doing telemedicine now, and I ask them, are you going to keep doing this? And they're like, listen, this is how I will keep doing it. So then I can relay that information to our portfolio companies and say, this is where you need to focus right now. This is what's happening on the ground. But to your question, your answer from period, I think systemically, I'm not seeing pundits out there who understand that model right now. It's been so rapid that it's come on that they haven't figured that out yet. So the ones who do figure that out and run that flywheel faster will win.
Fortunately, on our show today, next we're going to be talking to Susan Dentzer, who may be one of the foremost healthcare policy economist people who's looking to push forward this whole remote telemedicine agenda. So I'm wondering what you would say to her, or what request you would advance to her, or evidence you'd share with her to bring to regulators and to Congress from the front lines on to DC in our conversation today.
Yeah, it would be get them to continue to pay for it. It works. We've shown it works in this COVID time. It's better for the provider. It's better for the system. It's better for the patient. That the government should really enable telehealth and remote technologies. That sector of healthcare is in its infancy and is something that needs to grow. It's really important, and it works really well.
Well, Dr. Mehta, thank you so much for joining us today and giving us that. We've been doing this. This is, I think, our 32nd episode, and we started this in the middle of March. And it's kind of amazing that whatever it is, however many 14 weeks or so into the, it's still stunning how much you're learning and how much it's kind of still stat there at the front lines.
Yeah, it really is. So wear your masks, social distance, be good humans, take care of each other, and appreciate taking the time to go through this today. Excited.
Thank you for all that you're doing, and for what you and your team are doing every day. I mean, we recognize, at least Peter and I, how important it is for just the crazy commitment you're making, and you're putting your life at risk, and I understand that, and we really appreciate that.
Yeah, and good luck to everybody in Texas, because the Texas seems to be where New York was maybe 8 weeks ago. So,
yes,
thanks.
It really is. Great, thanks, guys.
Okay, Mick. Well, that was the first time we spoke with someone on the front lines, and it was both sobering, but also, very interesting to think through how he's navigating between healthcare investing and everything he's seen there in real time. Mick, you there?
Peter, are you on mute? Can anyone hear anybody? I can't hear you.
Am I on mute? Can anyone?
Now I
can you hear me?
Actually, you were on mute.
How's that?
Yeah, that's better.
Okay, well, now we're back. We're speaking in English.
Mostly.
We can hear each other. what I was saying when I wasn't saying anything was that sobering, because the first time we've actually
Yeah.
talked to somebody on the front lines.
Well, and I like his point of view that he's balancing.
And now we're about to,
so what he learns on the front lines right now, it's intense, but also it forces him to have a much deeper and richer perspective of what kinds of questions to ask as an investor, and as someone who cares about trying to help take this moment when it's 100% reimbursed to spin up a flywheel, build systems, and build something people love and need, so that they can actually be a voice for, when the economy settles or when something happens in the way the health reimbursement works.
Yeah, Amit has been working very much towards pushing healthcare to the edge, remote healthcare, essentially making going to a provider something you need to do only when you need to do it. And that was really what we talked to Susan about on April 1st, in our very first conversation. And, he made a wonderful point. I loved his point that this was unfolding in 3 acts. The first act was just figuring out what the heck was going on. The second was all of this hope that this is a time for incredible change, and we can bring in new devices, new technology, IoT, transform healthcare. And now there's almost an exhaustion, especially I think in Texas, where stuff's in the upswing of they're just trying to keep up. And I think on some level, nationwide, we're exhausted. And even on this show, we got very excited very early on that this is a time of fundamental change. And certainly economically, that's the conversation we'll get into. So when we started talking to Susan on April 1st, it was around what an amazing moment this must be for telehealth and remote care. And, the government had just decided they would reimburse telehealth. So we went back and checked in with Susan at the Duke-Margolis Center this morning. And she had just run a nationwide conference of healthcare policy people. So we're going to go to that next. And I think another thing that we'll listen for was this kind of potential difference between the excitement of dealing with this and the exhaustion or reality of what this has turned into. All right, Susan Dentzer, welcome back. We spoke to you on April 1st, and you are with the Duke-Margolis Center, and we talked a bit about remote medicine and preparing for this pandemic. A lot has happened since then.
You're not kidding.
So, so why don't you give us an update on, first of all, you've run a big conference on COVID recovery, and you must be looking at what's going on now. What's your sense for the status of where we're at, and how does this compare to perhaps where your mind was at on April 1st when we were first looking at this?
Well, thank you, Peter and Mickey. First of all, it's great to be back with you. In early April, we thought we were in the thick of the worst of the crisis. And of course, with respect to the epicenters at the time, New York in particular, we were. I don't think we could have foreseen what we are in today, which is, frankly, the thick of the worst of the crisis to date. And if anything, it is vastly beyond what we thought we were seeing in April. If you could share your screen and go to a website called covidexitstrategy.org. This is a compilation of statistics from various sources. It's put together by organizations, as you can see at the bottom of the page here, including our center. But essentially what this tries to do is aggregate everything that we know now about rates of hospitalization, rates of infection, judging from testing rates, and essentially aggregate all of this into what we are seeing now in terms of the spread of the disease, as I say, the rate of hospitalizations, et cetera. What this shows, again, is that things are about as bad as they could possibly have been at any point in the pandemic. If you look at this trajectory here, so here's where we were even a month ago in May, with essentially a couple of states really things improving across the board, a third of the country kind of holding steady, and about a third of the country things were getting worse. If we look at where we are today, almost the entirety of the country now is red. Things are getting worse almost every place. And that is not what we would have expected.
And is this because the infection started in a few places, principally the coasts, and then as they got better and there was a will to reopen, we lost our guard? What would the postmortem, if you will, tell us about what happened that led to this?
I think the postmortem would tell us that we were engaging in a lot of magical thinking about the virus, given how little we knew about it. There was a lot that we just didn't know about the science of the virus, obviously, but there's a lot that we didn't know because we weren't doing as much testing as we obviously should have been doing all along, and we didn't really understand the huge degree of community spread of the virus. And we also didn't understand that the risks to reopening were as great as they were. And that in particular, as we opened up, where we opened up in terms of states around the country, what happened when we opened up. And as we have come to understand, one of the biggest risks is meetings of any size in any substantial group, especially indoors. So that means when bars and restaurants opened up, and especially young people flocked to those locations, we saw just an enormous surge in the community spread of the virus. So now what we've got is a situation where a lot of states opened up, probably prematurely. Even if they didn't open prematurely, the human behavior that was necessary to keep the virus from spreading did not occur. There was not enough mask wearing. There was too much close contact, too much access to bars, restaurants, even personal gatherings of people. And the viral spread has taken off. And as we know now, also with the aid of additional testing, we're learning we have as many as 55,000 or more new cases materializing every day. And as Tony Fauci has said, very soon we could be on the verge of 100,000 new cases every day in much of the country. We have seen, obviously, in the most recent of days, some states dialing back on some of these reopening measures, but other states not doing so to any meaningful degree. And that would tend to argue for hitting the numbers that Tony Fauci is talking about, as many as 100,000 a day within a couple of weeks.
Is this going to normalize like our understanding? Are 100,000 dead? That was, the cover of Time magazine, New York Times a few weeks ago, or a month or two ago. Is that going to be like a daily average at some point? Like, are we normalizing this? I'm very worried that we're not even in the thick of it yet. What comes after red when we color a state red? Does it go some other color? This is disturbing. Yeah.
I think we're only in the thick of things to date, right? It could be getting even worse. And in fact, there's substantial reasons to believe that it will get worse. There was a belief that there would be more seasonality to this virus than has turned out to be the case. That is to say that in warmer months, it would abate somewhat. That's not proving to be true. What we are pretty darn certain of is that with cooler weather, there will be more spread. And of course, we're afraid that this fall season of COVID could also intersect with a bad flu season and a bad case, potentially even other viruses like a so-called RSV virus. So, you put all that together, there's every reason to believe that things are going to get even worse from here. And now that we're having additional discussions about reopening things like schools, and even we understand, of course, why organizations like the American Academy of Pediatrics thinks it would be better to get kids back in school than not. I think everybody agrees with that, but what is the cost, right? And not just to kids, but to teachers, right?
Well, I heard in Chicago that the teachers are being asked to come back in the fall, public teachers, but the teachers that have kids, because they're going to spread out the actual class size so that it's like half the class size Monday, Tuesday, Wednesday, and the other half Thursday, Friday, or overlap on Wednesday. The teachers have to work 5 days, and take care of their kids too, whereas the parents will be able to have like a few days where they're able to like hand the kids off to school. And so there's this kind of like not even paying attention to what it could mean to some of the most important workers, I think, in this.
And not to mention a lot of teachers are older individuals, and potentially at greater risk for those reasons as well.
What's happening on the policy in general, though, in your work, and maybe that's the transition to talk about what you just hosted.
I can ask you a question before we go on to policy stuff. Just in terms of how we respond to this, the pandemic presents a set of very tough decisions that individuals and communities have to make. And this is profoundly, because it's not a national response, this comes down to individuals and families and friends, and then, all sorts of mayors that are making these big decisions. And there are these tough trade-offs. I mean, first of all, and just personally, I can't figure out, like, am I supposed to be in a small pod? How would my pod of friends connect to another pod? What kind of tracing mechanisms do I use? There's not a lot of guidance on that, and yet I feel like I'm spinning up a piece of innovation around that, trying to figure out for myself what to do. San Francisco's opened up outdoor dining, and I'm trying to figure out how far that goes. So we're trading off these individual responses, what we got into last time, which was the need for an economy versus this, that I don't even know if we're further on that. And then how governments make the decisions. So I'm wondering if you just, almost from an ethical point of view, step us through how those decisions need to get made, what guidance for individual people, and what the guidance is.
Well, as you said, we know we do not have a national response to speak of at all. We've just had almost a complete abdication of any responsibility at the federal level to set any kinds of normative guidelines that states would be highly encouraged to observe. So that's gone. That's out of the equation. So we've left it now to governors and localities. And we know that those issues are playing out differently within states. You have states where the governors have forbidden the localities for setting their own standards around mask wearing and everything else. And you have states that have done the opposite, where the governors have said, okay, localities, you want a lot of leeway to decide whether you're still in phase 2 or phase 3. That's up to you. So we're seeing even that play out very, very differently across the states. The net effect of this is what the policy is where you are, right? And who's your governor and who's your mayor and what kind of relationship has been worked out among those levels of government. And that's, as I say, highly variable across the country. And so we're seeing a lot of natural experiments play out that are resulting in varying degrees of infection and death throughout much of the country. And as I say, I think on balance, the trends show that things are getting worse, and they're getting worse at a time when we need them to be getting better, and we would have every expectation they should be getting better, but they're not. And we're steering into a period of time where all the other external forces are going to suggest that things will get even worse from here.
What does the policy community or medical professionals think of both the magical thinking, the disinformation? So many friends of mine, bright people on Facebook, are either it's false, or it's overblown, or it's a conspiracy, almost a will to make it not exist. And this is, it's crazy making, not only because now I'm trying to make my friends wrong and I think they're crazy, but I also wonder, why is it that this is taking off in a degree that should be science-based? And I don't fully understand it, but it seems like the virus of the mind is as big as the virus in our respiratory system.
Yeah, no, absolutely. And I think as Tony Fauci and others have said, you have a large share of the American public now that simply rejects science. They just don't believe it. And anybody who is not rejecting of science and is following the literature and following the news knows that this is a very bad and dangerous disease and highly transmissible, right? And if you don't know somebody who's had COVID and you don't know people who've died of COVID, I suppose you can have one set of responses to it. If you know much about COVID and you know people who've died from it, you know what a terrible, terrible disease this is. we just had this very well-known Canadian actor at age 41 die of COVID. And what happened? He had such extensive blood clots in his body that his leg had to be amputated. Okay. He was told by the physicians told his wife that if he recovered, he would probably need a lung transplant because his lungs were so seriously damaged. And he died at age 41. And this was a very healthy man. Okay, so if you're willing to reject all of that and say, hey, not happen to me, good for you. It's really nice wishful thinking on your part that you're invulnerable, but you're not. And even if you don't die from this, we know that the long-term effects in terms of cognitive deficits, neurological impact, even just if you've had gone through a long period of hospitalization, you can be months in recovery from this, months. So if you're willing to take that whole body of knowledge and just shove it in a drawer and say it's not happening, good for you. It must be living in fantasy world, but it's really happening here. And again, some people have positives. It's going to take everybody in the country knowing somebody who got very sick and almost died of this to turn around behavior, and maybe that's going to happen.
Well, I worry too that this idea of a natural experiment, one that we did not set up, but it's just happening, right? Every single state, sometimes every locality, will lead to a preponderance, like a massive amount of evidence. But there will be conflicting evidence because, my uncle made it okay, or because Joe Bob did this, and hey, we closed down and nothing happened here, so we're opened, or whatever. Because when you don't believe in science, everything is evidence, right? Because the opposite of science is voodoo. If I slaughter this lamb, it's going to rain tomorrow. So shaman and witch doctors that are, able to point to anything, I think might be on the rise. I mean, are we entering dark ages 2.0? Because it feels like this is exactly what happened when the cholera virus hit, or the cholera bacteria hit London in the 1600s. And the mayor was like, oh, it's bad moral fiber. That's why it's hitting in this area. And then, the townspeople didn't understand it until, a citizen scientist went and took the pump handle off the water pump. And it feels like we're just entering that one more time, because now it's almost willfully not believing in science. Before, we didn't have the scientific method really well established.
Yep. And what's so ironic is, this is at a time where our science it's not perfect, but it's better than ever. And every day we are learning more and more about this virus. To wit, this very recent analysis that showed that there were genetic variants that contributed to the severity of disease that were related to how much Neanderthal DNA you have in your ancestry, okay? We were in no position to know things like that even 5 years ago, right? And so the science is better than ever, and it's evolving. It's going to continue to evolve, but we know more than ever. We have had this debate now about whether the virus is aerosolized as much as many scientists do believe. And, the World Health Organization has been saying the primary mode of transmission is large droplets, not these tiny aerosolized particles, but clearly it's both. So we know a ton. And if you look at the science, you say, wow, we're learning a lot. There are lots of really important things coming into our understanding about the virus that we will be able to turn over time into more effective therapies and treatments. But right now, what it tells us is the best thing that we have continues to be physical distancing, mask wearing, and avoiding getting this in the first place.
All right, that was sobering and fact-based. You just had a conference on policy response to COVID. Tell us a little bit about kind of the hypotheses and what you wanted to discover in that event and what you learned last week?
Well, when we conceived of the event, which was actually back in March, we thought that, as many people thought at the time, that there would be this terrible first wave of the pandemic. We didn't know what the scope of that wave was going to be, whether it was in fact going to be national or not, as it has turned out more or less to be. But we knew that some of the worst affected areas at the time, New York, Michigan, Massachusetts, New England, we knew that there had been this terrible toll on the healthcare system there, not just because those systems had to move into surge capacity to deal with the pandemic, but also because elective surgeries had been canceled. The whole financial structure of a lot of US healthcare had pretty much imploded temporarily, that we had to have federal stimulus monies come in. We had to advance a lot of Medicare and other payments to health systems. So we knew that there was going to have to be a recovery from all of that. And so what we conjectured is we need a conference to explore what is the route out of this for healthcare systems. What we didn't necessarily imagine was that we would be talking about, yes, recovery for a lot of systems, for example, in the Northeast, just as many systems in the rest of the country are going into, the terrible realm that they are now in, where ICUs are filling up. They're going to have to expand surge capacity. They also now have had to suspend elective surgery, which is the bread and butter of the healthcare system. Patients are afraid to go to hospitals or even their doctor's offices for care. So the financial infrastructure of the healthcare system in this country is, if anything, in worse shape than it was even when we started to conceive of the need for this conference. So what our conference, in essence, was struggling with is, how bad is it going to get, both in terms of the prevalence of COVID-19, what is going to be the impact on the healthcare system on an ongoing basis as this continues. We know that, for example, just in the first quarter of this year, as the shutdowns started to play out, as elective surgeries were canceled, just even at the end of March, we had a 5 percentage point decline in the GDP in the first quarter of the year, and 2 percentage points of that was the impact on the healthcare system. So even in the very earliest days, there was this huge economic damage that was occurring in the economy and to the healthcare system. Since then, we've had ongoing financial issues for many institutions, massive job layoffs in healthcare that continue to this day, right? And now we're trying to figure out, again, how long is this going to last? How much worse is it going to be? How bad is it going to be? And how do we keep these systems going? Because, frankly, we need them, especially now. And as we think both in terms of, how do you do this operationally? How do you bring back elective surgery when you can and at what pace? And then how do we deal with this from the standpoint of policy? Billions of dollars of Medicare payments got advanced to healthcare providers through a couple of federal programs. And those advanced payments are tied to interest rates, and they're loans that these institutions have to pay back in about a year. They're not going to have the wherewithal to pay them back. They just won't, at least as we can see now. So what do? Turn those loans into grants, forgive them, which I think we pretty much have to do. These are all just really critical issues that we don't have clear answers for, and we're going to have to work it out over the next months.
What were some highlights from the conference in terms of either a research team doing something that really was provocative in terms of some of the states or cities that have started recovering, or anything that really stood out to you that surprised you a little bit, or maybe got you excited about something?
Well, it's not a big list, but I think some important takeaways were, first of all, 4 organizations that were in newer payment models, right, where you're not being paid exclusively on a fee-for-service basis, but you're being paid under, for example, population-based payment, value-based payment, even capitation. Those organizations were in a lot better shape than the organizations that were dependent on fee-for-service payment. So if you take a primary care practice that was being paid on a fee-for-service basis, okay, so what happens to them? Patients stop coming, patients are told not to come, things close up, they're dead. They're dead in the water.
Yeah.
Very thinly capitalized, maybe 30 days of cash on hand. They got walloped. If you were, by contrast, a primary care practice that was being paid on a value-based payment basis, or was in an ACO or whatever, you first of all, if you had any population-based payment, you were getting paid regardless of whether people were coming in or not. You have the wherewithal to turn on telehealth, for example, more quickly. You have the wherewithal to basically redirect your staff away from just processing visits, right? So those organizations that have moved to more value-based payment are much, much better off in this current environment. And what that tells us, I think, is going forward, we just have to continue that move very broadly. And I think many people believe that will be how we begin to put Humpty Dumpty back together. Yeah.
One of the things we talked about at the very beginning was that this was an important moment for remote medicine and telehealth. First of all, we didn't want everybody crowding into the hospitals, and secondly, as this started, people were doing telehealth doctor sessions where we were beginning to use a video. Just prior to the segment, we talked to Dr. Amit Mehta, who is both a physician and an investor. He told us that it was exciting that 100% of these telehealth visits were now being reimbursed, because oftentimes they're not. And he was learning that these were incredibly efficient. Patients loved them, and it seemed like a very important part of the toolkit. And yet at the same time, it was very unclear to him as an investor and for his practice if this would continue after COVID, if Veterans Administration or Medicare would continue to reimburse for telehealth visits in downtown areas, since so much of the medical care system was based on coming into the office. This is an area of your policy expertise. What's your take and what's your guidance on this whole arena?
Well, sad to say, because the pandemic is getting worse, I think that bodes well for ongoing, in the lingo, it's known as parity of payment. So office visits and telehealth visits are being paid now in so-called parity. The public health emergency, as we know, is due to expire July 25th. It's very likely that's going to be extended now for at least another 3 months, if not beyond that. CMS has shown every sign of continuing to pay at parity and continue to suspend a lot of the regulations that have been suspended over the course of the public health emergency to date. So, for example, CMS has allowed a lot of use of so-called non-HIPAA compliant platforms to do telehealth. So you can use FaceTime right now and be reimbursed for seeing somebody over FaceTime, even though technically speaking it is not HIPAA compliant. And a lot of states are going to have to continue their relaxation of regulations. A lot of the states eased up on licensure restrictions that could get in the way of doing telehealth across state lines. They will be under pressure to keep that relaxation of restrictions in place. So I think for the next 3 to 6 months, we're going to see the status quo of today perpetuated, and that there's going to be a lot of payment for telehealth going forward. Now, what happens beyond that is the larger question. CMS has signaled that it is not going to go back to the way things were. It's not going to go back to the world where you couldn't do telehealth into a patient's home under traditional Medicare because the home was not an allowed originating site, right? CMS has said, more or less, we're not going back there, right? The cat is out of the bag. We're going to incorporate more telehealth and pay for more telehealth broadly. And of course, on the legislative side, we do have signals also that at least the Senate Health Committee held a hearing about a month ago where it was a pretty clear indication that they expect to make some legislative changes to cement more ability for Medicare to pay for telehealth in the future. Now, what else happens? It depends on what commercial payers decide to do. It also, frankly, depends on what patients want. Because if patients have decided that they really like this, there will be much more pressure coming from consumers to keep telehealth in place. And then in addition to that, we've had a number of other market forces changing the dynamics around this. Google has started a virtual pilot where you can look on your phone and MapQuest, and we'll be able to do this in increasing parts of the country and see who's out there providing virtual care. And if you as a consumer want that, you're going to have a pretty easy platform now to find out where that's available. So as all of these things come together, I think it really drives in the direction of more allowance of telehealth going forward than we would have suspected even a couple of months ago. And as the pandemic continues and rages, I think that's a virtual certainty.
What are we learning about the efficacy of it, how well it works, how much more efficient it is? And also, in fact, is this something that doctors and patients find that they really like and is working?
Certainly on an anecdotal basis, everything I've heard from the majority of clinicians and patients is that they like it. And actually the clinicians are surprised at how much the patients like it, and they're surprised at how much they like it. And I think everybody is now in the mode of thinking it's not a good idea to go back to what we had before, but how do we think through what we would construe as hybrid models in the future? Mm-hmm. So when do we think we really need to see a patient, and when do we think a virtual visit suffices? And what kinds of capabilities exist across different aspects of medicine? And that varies as well. Obviously, if you're a surgeon, you're not spending a ton of time thinking about how you're going to do surgery via telehealth, but you are thinking about things like, can I do after surgery visits by telehealth? Can I have consultations with my patients before they come in for surgery via telehealth? And so thinking about how hybrid models of care work across different medical specialties, I think, is going to be the primary focus going forward.
A few weeks ago, we had Andrew Hessel, who works in the synthetic biology world. So, he's one of the co-leads of the Human Genome 2.0 project, where we really look at whole genome foundries, which don't exist today. There's been this massive flow, investment, town halls, global networking around synthetic biology, clearly looking for a vaccine, clearly looking for how do we actually move the biological world into the digital world so that we can actually share and process it and apply all those things. Are you also seeing investments? I mean, literally just like last week, I think a major SynBio group got an $800 million investment, that's doing something interesting. Are you seeing similar investments or similar moves in telehealth in terms of actually big investments, big investors saying, I'm really going to make a difference here? What's happening in that regard?
I wouldn't say so much outside investors investing heavily in telehealth, although the stocks, obviously, of the telehealth companies have done well in this environment. I think now it's really a question more for health systems to think about the investments they are going to make, and how are they going to do that? Are they going to acquire, basically build their systems on some of the existing commercial platforms? Are they going to try to grow their own? Those kinds of issues are really at play for a lot of health systems going forward. I think that, the technology here is not the rate limiting factor. There are lots of different platforms you can use for telehealth. There's going to be a lot more investment in remote monitoring and other technologies in the home, right, to monitor patients to various degrees. And I think you're seeing more money pour into those other applications that we don't, strictly speaking, classify as telehealth, but they clearly speak to these distributed care models where you're essentially treating patients more and more outside of conventional institutional settings.
You know, you said something that I thought was kind of curious, in that, you know, people are really, doctors, clinicians are really thinking maybe more exactingly or more specifically about what you really need to come into an office for versus what you can do. A surgeon, obviously, it might be hard to do a heart surgery remotely, but is that coming? I just am curious because I saw that, you know, kiosk down the street that served me coffee with a robot arm. And is there a day where I'm going to walk in and get a heart transplant, you know, from a networked robot arm? And I asked that question. I know it's silly, but just a few weeks ago, we had Ashley Arhart, who was the chief experience lead for Amazon Go stores. And she was both at Microsoft leading some of the work around ambient intelligence and consent. And the idea was, when you walk into a Go store, you're actually walking into a robot. It has tons of sensors. It knows if you got one or two things, even based on the reflection. It understands if you took it. She said, how do you get consent? How do you cope with these things when you're in an ambient intelligence in a space? Are we going to move in that direction, do you think? Or do you see that the healthcare world is just so restrictive, or that it'll have to come from the systems as you as from outside innovation? Where do you see that going in terms of the more extreme?
We're definitely moving in that direction. There's no question about it. And we already have robotic surgery. There will be more robotic surgery certainly in the future, and remote performance of surgery as well. So that's definitely coming. It's just, you know, it's probably going to take longer than just having a sort of more of a cognitive visit, a telehealth visit, for example.
It does seem like we're hitting just a moment when you talk about like remote monitoring and remote sensing. I think of the brilliance of the Apple Watch, which is a consumer device that millions of people have, and underneath it in a sandbox are FDA tests going on. So a way of diffusing new forms of connections between providers and patients. And I'm imagining that, you know, whether it's a blood glucose or deeper heart kind of things, we must be at a point where if you get the silicon and the math out there, things will look very different in terms of what can be monitored and how in the near future.
Absolutely. Absolutely. So at every level, from the simple to the complex, we're seeing much more application of all of this, including AI. So a lot of the systems that have built COVID screening applications on their websites built them off of chatbots, right? And you're going to see, just even at the simplest level, more and more and more use of chatbots for healthcare as screening devices for people. And then moving on to much more sophisticated and elaborate delivery of actual care that is also AI enabled, et cetera. So yeah, it's coming.
I have a final question before we wrap up. We've talked a lot about and physical health. This has been a mental health crisis, both because people are cooped up, because they don't have the connections and can't see the therapist. What have you seen in the both telemental health and just for the policy change of mental health and its providing in this crisis?
An explosion, a true explosion of telemental health at all levels, including within health systems themselves to support their own providers. Providence Health System on the West Coast being a case in point, where essentially they built a system to support their providers. And we're really gratified that 20% of the people who accessed their internal mental health support system were physicians. That's how traumatized providers have been in this whole pandemic experience. So just an enormous explosion. And again, you know, good thing, because as we know, one of the huge issues in mental health care has been access at all levels to appropriate mental health providers, largely along geographic lines, but also along socioeconomic lines. And as we've had now the ability to get frankly, cheaper forms of support and also more remote support, that has been a blessing and one of the few silver linings in this crisis, that we've really now got complete proof of concept that we can provide a very important support to people in the mental health sphere at a distance, in a timely way, and at less cost.
Susan, thank you. This was a very powerful check-in, both on the status of where we're at and how much further we have to go with COVID, the policy response, and then some of this thinking about advances and how we'll keep up with them policy and government-wise. Mick, I'll turn it over to you.
I'm so glad that you joined us, Susan, and I feel like I could probably keep asking questions and poke around on this for quite a while. I appreciate your patience and looking at the long view, and I think that's really an important part here, is looking at where we can do this, and also just your leadership in this. I appreciate that, and thank you for all that you're doing, and I think raising awareness about this is really important.
Susan, in our next segment, we'll be going over to Marco. You may remember on April 1st, there was a conversation between you and him. He's like, we have to get the economy going, and you're like, not so fast. Since he's on the next segment, is there any advice or counsel you'd like to give Marco before we turn over to what to do about the economy?
Give us some sense of clarity from your perspective about how we continue to reopen safely in an environment where we want to minimize a lot of person-to-person contact, a lot of group contact. How do we operate schools differently? How do we operate workplaces differently in this environment? Because I agree, we can't let the economy completely crater.
Yeah.
But how do we do this in a way that is safe?
Yeah. Well, perfect setup for Marco. Thank you so much, Susan.
Thanks.
Thanks to both of you. Great to be with you. Take care now.
Well, we've traversed this revisiting of healthcare, both where we're at, not the strongest report card, and some of the futures, and also make this conversation that we had with Susan and with Marco on April 1st. It was one of the first conversations about reopening the economy, because at the very beginning, everybody was just sheltering, right? And then we should bring Marco on. Marco kind of was advocating for thinking through opening of the economy and favoring that, even as we saw Italy in crisis. And Susan, I think, in that initial call was like, how can we think about that now? And we were all thinking things would be in a lot better shape than now.
Although, I think the thing was that Susan had a lot of optimism that by maybe June or July, we'd have a testing regime in place, or we'd have some things going. She did say, though, that things like the serology testing at any kind of scale, that we could really have data, which would actually be if you have antibodies, if you have some immunity. We have still not really gotten very far with that in terms of large scale testing, particularly in the US. There are serology tests. They were fast tracked by the FDA. A lot of people I know that are in the synthetic bio world say they take about 5 different tests before they actually decide if they even trust one of them. So there's a real challenge right now, even with that she flagged was going to be a big issue, and it continues to be. Marco, what was your reaction to some of the comments that Amit or Susan made? What are some things that have come to mind as you've been watching and listening?
Oh my God, there is so much. So let me start with some of what we heard from Amit, which I thought was very, very interesting. So first of all, extremely encouraging that clearly we're making progress in understanding how to deal with this disease, with COVID-19. And I think this is helping enormously. And you can see it in the numbers, because and here we'll bring in something that struck me from Susan's a part of the conversation, which I actually disagree with, when she said that we are now at the most dramatic period, a lot worse than it was back in April. I disagree, because one thing we're seeing is, yes, infections are rising, but the share of new cases that end up in the hospital is decreasing dramatically. The share of people who are in the hospital who need to get into the ICU keeps decreasing significantly. And I think this is because in the hospitals we have understood how to do a much better job at curbing this disease. So these I found extremely interesting. Another thing that I found very interesting was, and this comes from both conversations, both Amit and Susan, the issue of a greater reliance on telemedicine and using it also to make the US healthcare system more cost efficient and therefore able to deliver better health outcomes at a lower cost. So that I found extremely interesting. And what Amit was saying was how this, much as we would love not to be in this situation, but the stress created by COVID-19 is creating a laboratory that forces healthcare providers and hospitals to experiment with new strategies, new procedures that hopefully through then venture capital investment and new technologies and startups and new business models will get baked into a better healthcare system going forward. That I found very encouraging. There was a lot more, but let me just stop here before I repeat almost every single point that came up in the previous two conversations.
In preparing for today, I was going through the Wall Street Journal and just snapping some pictures of some headlines. So, Amit, if we put up our lightning round images, I just want to kind of share with you some headlines and then just get your reading on either optimism or a sense for what happens with segments. So, first of all, we've seen a huge speeding up of the demise of a lot of retail in the U.S. and of bankruptcies. A friend of mine who's a bankruptcy lawyer says he's never been busier, and it's as shocking as kind of being in the middle of healthcare. So here's Brook Brothers, which old line brand, which filed for bankruptcy today, and there have been countless ones in the entertainment sector that are reorganizing. Let's take a look at the next slide. So United Airlines, so these airlines all got a fair amount of federal aid to then pay employees on the assumption they were coming back. United was scaling up to bring back 25,000 flights for the summer 3 days ago. And then there was a spike in cases, and they're like, okay, we're going to try to lay off maybe half our staff. This was just today's headline. Let's take a look at the next. All right, this is an interesting one. Here we're adapting to reopening. They opened the theme park with the roller coasters, and then they told everybody, don't scream because it's not safe to scream. So I've just,
Wow.
we have here a combination of wrenching economic change and human adaptability at its strangest. Okay, let's take a look at the next one. Okay, now here's another adaptability thing.
By the way, at Disneyland, nobody can hear you scream. I think that's the new tagline.
So we've seen. Look, we've taken a look at the retail sector that's in bad shape, at the travel and entertainment sector. The whole bit about home, boy, that's changing pretty quickly. Atlantic had a very interesting article on kind of the rise of the suburbs, so the less open plans in house, because we all need our video studios. And now here's a nice one if you can afford it. The putting green coming to you, which is also the gym coming to you. The Atlantic article talked about the fact that home builders and hoteliers were now thinking of just sticking a Peloton in every room because just too much risk to go build the gym for everybody. Let's take a look at the next one. Oh, well, this is about the, this wrenching problem between small business owners and government policymakers, right? And so we've seen a lot of resistance from business owners who want to reopen. Policymakers say it's dangerous. And here at the front lines of that in Arizona, which is as hotspot as it is, the guy runs a gym and he's making his own policy. He's basically like, my trainers are independent contractors. They're going to just sign up 1 or 2 people at a time. So he's basically invented his own policy here. He's like, I made up some rules. I'm going to violate what the government says. I think I made up some policy here. Let's take a look at the next one. Right. Okay. And real estate. Right. So this is if you're in the downtown commercial real estate business, you may be in a very slow business. So I think that may be it. Omid, are there any more in this sequence?
Seems like it's plenty.
Yeah, okay.
Plenty of bad examples.
So, Marco, what I'm sharing with you here is, in general, this doesn't feel encouraging. This feels like big parts of the economy not doing great, really interesting adaptation in some areas. And I guess, my question to you is, what's our, when we talked before, we were talking about a V-shaped recovery. Robini there is like throwing that out with the Bashwater, and Stiglitz is saying we'd have to do a big revision to capitalism. So how do we approach this question at a time of such uncertainty?
Well, it really depends, again, on how we want to manage this trade-off between health uncertainty and economic uncertainty. So let me take a step back, Peter.
Yeah.
Going back to the conversation we had in April, where I was not just pushing for reopening regardless. What I was saying at the time is, number one, that I thought if we could reopen by June, we could have the conditions for a pretty healthy recovery of the economy. And I still believe this, and I think the numbers we've seen recently bear it out, and we'll go into it in a moment. But also what I was arguing was we need to take a very sober look at our situation. There's a lot we don't know on the COVID side, which also means we don't know if we will ever find a vaccine. We don't know if and when we will be able to eradicate this virus. We knew even then a few things, which are the mortality rates. And we heard some of this from Amit, which is, Amit pointed out the issue of comorbidities, how important comorbidities are in raising the risk of dying from COVID. We already know before that the risk is enormously different across age categories. So what I was arguing at the time was, let's try to figure out ways in which we can safeguard the vulnerable parts of the population and reopen some pieces of the economy. Now, since then, what have we seen? We've seen that as some states in the US have started to reopen, the numbers, the economic numbers, some of them have rebounded in a spectacular way. We had lost 40 million jobs, and then in 2 months between May and June, we brought back first 2.5 and then 5 million jobs, a lot more than expected. We've seen a rebound in retail sales, we've seen a rebound in consumer confidence. So we've seen signs that if the economy could restart, we're still in a situation where people are ready to go, the businesses are ready to go and to rehire people. So we could still limit the damage. We've also found, I think, that we still don't understand very well, and we're not having a very clear discussion on the reopening strategy. I'll give you on this just one simple consideration. One of the new hotspots is California. Now, California was the first state to go into lockdown. It essentially never came out of a lockdown. California hasn't reopened to any significant extent, and it has the toughest restrictions. So on the one hand, we go out and we criticize, say, Florida and Texas, and we say, well, those guys were crazy and reckless. They just were too eager to reopen. But then you have California in the same situation, and California hasn't reopened. So, and we're not having a honest conversation on this, which I think makes it hard to move forward. Now, I'll give you one more consideration on this, and then I'll pause. But I think part of the problem, and this is important in figuring out how we go back to some sort of economic recovery, gradual and safe. I think part of the problem is that people are not reacting in a rational way. This is something that Amit pointed out. He was noting how he gets crazy when he sees people partying in Michigan. That's fair, but we should also understand, and Susan kept saying that there are too many people who don't believe in science. But the problem is also that from the point of view of the experts, we haven't really had a honest conversation with people. So we've bombarded people with examples of young victims of COVID without being honest about the different mortality rate by age. And then unsurprisingly, what we saw yesterday, a poll by YouGov, which shows that in the US, the public's confidence in health authorities was low to start off with by international standards. It's plummeted. It's gone down 15 percentage points between mid-March and now. And then we have the problem that people don't trust the recommendations and don't do the simple logical things like wearing masks and to some extent social distancing. So I think this is, I mentioned at the beginning of our conversation today, it's the part that I find really dispiriting, which is that we haven't made much progress in how to have a rational conversation on this. Last comment, going back, bringing it back to the economics, the numbers you were showing, the slides you were showing, I think they're very troubling, because the fact is, if we now have to go back, if we feel we have to go back in lockdown, we will again lose millions of jobs. Then absolutely we go into an Uriel Rubini scenario where we are not going to have, forget a V-shaped recovery, we are not going to have possibly any recovery at all if we don't reopen until the infection rate is down to 0. Now, if that happens, I'll bring it back to Susan's discussion. She was saying, well, the hospitals are in trouble, they need money, they might need loan forgiveness. And yes, they have lost a lot of money. They had to fire a lot of people because of spectacular miscalculation, because we kept a lot of hospitals empty, waiting for COVID waves, which in some areas never came. But now as we go forward, do we need to pump more money into the healthcare system? Yes, into the airlines and into a lot of sectors of the economy if we don't reopen. But where is that money coming from if the economy doesn't restart? This is what troubles me the most.
Yeah, I think there's a weird thing that has to do with sort of, well, just do it, just pay for it. But at some point, if you don't have any tax revenue because nobody can pay taxes or things like that, it turns out to be a little bit of a trick. I think your comment about having an honest conversation or having a rational conversation, I think that is not only, your YouGov comment on the survey. My question would be, was that a decline in confidence because not having a rational conversation, or a decline in confidence because of enemy action? In other words, has the idea of having a rational conversation been so attacked by social media, by the rise of pundits and by the rise of algorithms that effectively just distort the conversation for political gains or for undermining a democracy, that is exactly what you would expect if you happen to be the person doing the undermining. Like if you were actually saying this would be a cool way for me to do it. It's pretty cheap. I can swipe my credit card. I can pay for some algorithms to undermine this, to amplify stupid messages and make it harder and harder to have a conversation. So I mean, I think there's that too, which I have to question: is this enemy action?
There is definitely an element of that, but I think just as important, at least in my opinion, has been the biased way in which, not even biased, the fact that many of the mainstream media have adopted exactly the same tactics as social media. Yeah. So they have internalized the goals of the enemy action. And I would add to that the fact that policymakers have also failed us, because across the states, governors have imposed restrictions which somehow were so arbitrary and capricious that they could not but undermine confidence in the health authorities.
No, I agree with that. Yeah, no, I'd agree. But I do think that there's this question of sort of when you really maybe spend the time to really drill in on the information and the evolution of the disease and what they're starting to find out. There's a lot of amazing new work being done. Yeah. I would almost want to say, let's praise the epidemiologists in some ways, but they're not going to really tell us anything for a few years because they're epidemiologists. They'd like to have a nice sample size. So how do we balance this, distrust in science from whatever the case, or even doctors, because doctors are a category, I think, of people that maybe do scientific method-based things or try to. And policymakers who have obviously at the federal level abdicated responsibility on maybe even doing some of that enemy action. How do we get out of it? Like what's the economic play here?
It feels like in addition to balancing it, Marco, what you're suggesting is that all of us come into it, or policymakers, the media comes into it either with a bias or a theory of kind of how things progress, a causality theory that we don't self-challenge. So, for example, you made an interesting point that here's California that shut down, and so for everybody who thinks that's a good idea, it was wonderful. We cheers ourselves, and yet California is seeing a resurgence while it's mostly closed, which might challenge the notion that perhaps reopening is the cause of the spikes if we haven't been reopening as much. So on the one hand, we could say people who are trying to push non-science or non-truth are around us, and surely they are. But perhaps many of us who think we're following the scientific method or are learned are following either a bias or making an assumption about causality, which you're suggesting we need to challenge. And perhaps because this whole thing is new, it's not like everyone's running around having gone to school on this stuff. So could you unpack that a little bit? Because I think I'm getting more sensitive to seeing what you're saying here.
Yeah, so and I agree with your remarks, Peter. There is, I think we have not been sufficiently honest, and by we, I mean everybody who goes in front of a camera to talk about this stuff, and especially the policymakers and the media, sufficiently honest to say how much we don't understand. We're always too quick to pick a couple of countries and compare them arbitrarily and say, see, the comparison between these two countries shows you that reopening restaurants is bad and reopening schools is good, or vice versa, without instead saying, look, there's a lot that we don't understand, but we're making progress. In the progress that we are making, here are some ideas that seem to be sensible. And again, wearing masks. But we talk about wearing masks. Let's remember, Dr. Fauci himself started off at the beginning of this crisis telling us not to wear masks. Even though he now says he knew the masks were needed, but he said, well, I essentially said, I was worried you guys were going to go out and stockpile them like you did with toilet paper.
Yeah.
So I think that we need to make a bigger effort to be honest about how much we're learning, how much we don't understand yet, and then say, okay, look, yes, we don't understand everything, so we are puzzled by the fact that we see the same resurgence in California, which never came out of a lockdown, as in Texas, which instead reopened more fastly. But to move this forward, we believe this might be because maybe too many people are out partying even in California without having the reopening announced. Maybe we understand that this is because by locking down people forever, you create a rejection, especially from young people who always feel invulnerable, always through history. And after a while, if you're telling them, sorry guys, you can't see your friends, you can't party, you can't do anything until we find a vaccine, at some point they're going to react. And since we don't have a police state, you can't monitor them all 24 hours a day, at some point they're going to gather and you're going to have it. So I think we need to be a bit more honest in telling people, look, be careful, wear masks, because otherwise it will not be at the end of the world. You might not die, but the infection will restart and you might infect somebody dear to you. We should also, today, for example, I would like to see a more informed conversation about the pressure on the healthcare system, because it is true that there are hospitals where capacity is being reached, as we heard from Amit as well. But it's also true that if I look at the CDC data, what I see is that even the most under pressure states today have about 25 to 35% available capacity in terms of hospital beds and ICU. So why can't we have a conversation that says, okay, guys, this is the situation, guys, meaning everybody, all of us, this is the situation. This is how quickly hospitals have been filling up over the last 2 weeks. This is what we need to do. Instead of just having headlines that say, this is the end of the world yet again, and the hospitals will be all full tomorrow, we're all going to die, which seems to be what we hear in the press and in the media every day.
Well, I think you're totally right about that. This idea of having a nuanced conversation, and maybe the fact, and I'm curious about your reaction to this, maybe the fact that this is a giant natural experiment, whether we like it or not. In other words, there is no top-down guidance. There is no grand leader that tells us what to do. Is the fact that at different states and different cities and different municipalities, that there are so many experiments going on, actually going to be telling? It's going to tell us something. It's going to cause a lot of pain and grief for some people, but is it that this is the way forward, is to just say, okay, I guess we'll see? I mean, the only thing I worry about with that is that there's so little sensing. The sensing of whether it's testing, whether it's whatever. I would feel better if I could sense, because I think a lot of times we make these assertions about this state or this country or this whatever, but we don't really know, because we haven't really had a consistent global sensing, tracing, anything. And there are all these hidden variables, like kids actually getting together because they need to, they're just kids, or people saying, yeah, we all tested, we're all good, let's go just get together with a social distancing party in the backyard. But we don't have any detection of those things that then may say, how do we learn from these natural experiments? I guess I'm just curious about what's the bright side of the fact that we have such horrible adoption of some basic things and such unnuanced conversations.
So for me, the fact that we've had different standards and different policies across the country, state by state, county by county, for me, since day one, I thought there was a positive factor, partly because, as you said, Mick, it creates a natural experiment in a situation where we actually don't know. Yeah. It's actually sensible to try different things, but also because
go in parallel. Yeah,
exactly. But also because the different states and different counties have different conditions, so they might not all need the same policies and the same restrictions. Right. So I always thought that, but you're also completely right in the second part of your statement, Mick, which is what we're missing today, again, is the ability to harvest the data that we are creating through these different experiments and being able to compare them in a rational, cool-headed way, and to say, okay, this is what we're learning, this is how it works, this is how it does not work, which again, just to steer it back towards the economic side, I think it is important, because it will help us. And this is the question that Susan asked at the end of her segment, right? How do we reopen safely? And part of the answer is we need some more information on what activities cause more infections than others. The other part of the answer is we need to try to use the information that we already have on the comorbidities, on the age vulnerability, and then we need to try to decide how much risk on the COVID side do we want to take, and how much do we want to pay, not just in terms of money, on the economic side. So what I mean is, Peter showed us a number of slides which showed the travails of sectors or industries ranging from airlines to retails. And we know the sector of hospitality, restaurants, bars is also under tremendous pressure. We know that the initial 40 million jobs lost were concentrated overwhelmingly in the most vulnerable sectors of the population. People with lower skills, lower wages, precarious jobs. So if we decide, for example, that the data tell us that we should potentially never reopen bars and restaurants, maybe that's the conclusion that the epidemiologists will come to. Then we need to have a conversation and say, okay, so what do we do with the segment of the workforce which is in those industries? And even before we get to that point, we need to have a conversation on, okay, for how long do we want to wait? Are there situations in which some of these industries can gradually reopen? That, to me, is the toughest part of the question on the economic side.
I feel like you have leaders who, I think rightly so, want to sound confident and want to be able to have an answer finally, because of various reasons. And so, I mean, I can't say there's anything wrong with that necessarily happening. That's part of human nature. And I think what's weird is that we're experiencing human nature as a natural experiment as well. Like, everybody gets to experience human nature what isolation feels like, what loneliness feels like. With the rise of the Black Lives Matter movement and defund the police, we're also getting to see that like these marginalized communities that have historically had algorithms that helped them be incredibly unlucky and made them unluckier are coming to the fore. We're actually having different conversations. So I guess, I'm curious about, a part of me feels like we've entered a new dark age. And I don't mean a dark age necessarily like the first dark ages that we talked about, sort of pre the scientific method. But, they were dark because we didn't have a scientific method. Now we have a scientific method, although we all doubt it. But now it's almost like nature is telling us, you're not so special. It turns out it's harder than you think to have a global society that moves around the world and that does all these things. And we're going to have to get through the dark ages again. But this time it has so much to do with both human nature, mental health, leadership nature, creativity and imagination, as well as natural phenomena like the virus. Peter said it, the mind virus and the COVID virus. And yet there's also so many of us, even if we want to help, when we grab a hold of a piece of information and go, see, that proves it. We're not having an honest conversation because, we're just so hungry for certainty. And how do we get to this place where we can be comfortable with understanding that there are trade-offs in this uncertainty basket or set of baskets? And I don't know. I'm just curious, what gives you hope in this, I guess?
I was earlier going to almost interrupt you and say that you're starting to sound like an economist when you warn of another dark age coming. That kind of pessimism belongs to us.
Right after that, I'm actually very positive. I know I should just keep my mouth shut or else I sound like an economist. The dismal science. No, that's your job. Come on, Marco.
No, so
cheer me up.
I'll cheer you up in the sense that I think the way in which our healthcare system and our economy has withstood the shock of this pandemic is actually remarkably positive, remarkably impressive to me, especially if you put it against the background of all the criticism that we've just finished piling on to everybody who's in charge. The system has held up reasonably well. We've had 3 months of this, and yes, the death toll has been terrible, but it has not approximated the plague that somebody in the White House kept talking about. And the economy, yes, it's taken a tremendous hit, but we are not yet at the levels of the Great Depression. So that gives me hope. I try to take a positive view of the turmoil we see today across our society. I do think, as you're suggesting, Mick, that it's overdue for all of us to rethink some of the mechanisms we have in our society. What worries me is when I see that there is a temptation for this reaction to go in the direction of breaking everything that we've built so far to rebuild it anew. And that, I think, might be a very costly mistake, because flawed as it is, the kind of system and society we have built so far has delivered very impressive results in terms of improvements in quality of life and standards of living across the board, with inequalities that we need to eliminate, but standards of living have improved across the board. So going back to the discussion, the references earlier to the crisis of capitalism, I always worry. You asked me to be optimistic, so I will be optimistic that we will be able to go through this as a gray age where we keep at least 80% of the good stuff that we've built, and maybe we throw out 20% as the cost of transforming ourselves into something even better down the line. How is that?
I like that. Actually, a gray age, that's not so bad. That's reasonable. I like that. Well, and I do think it's kind of amazing to me how much just keeps working. Because I do think it's surprising, and I think that there is an innate resiliency in humans and in these systems, some of these systems that have been built, and it's not great, but in many ways, but historically, it has certainly delivered an awful lot for humankind in general. Peter, where do we go from here? What's your
I was
ending
actually on
question?
last Friday's show. Was concerned with this whole bit of connecting to how we've built our past and not throwing things out. We actually went back to we talked. We had Bill Cathers on, who was an Aspen Institute moderator, and we kind of, because it was the 4th of July show, we hold these truths, and I think part of the thinking of the show is oftentimes we have a cartoon version of America in our heads, where we'll say things like, we have liberties, we don't have to wear a mask, but we don't understand that Locke told us there was a distinction between liberty and license, and we have to know where these things come from. And I was just looking for the quote. We were quoting Barzan, who was essentially saying, if you throw everything out and reinvent it, you're going to be in much worse shape than if you build on the past. This is the whole premise of the show, and you've just made that point there. I feel like there's one very positive thread here that we've seen building for several years, which is kind of a realization that the way that global capitalism has been practiced for the last 30 or 40 years is due for an upgrade. Capitalism got an upgrade in the progressive era, 20, 30 years into the Industrial Revolution, when you had Teddy Roosevelt and child labor laws, and we passed rules about you can't lock people in the Triangle Shirtwaist Factory and such, and that was a progress. And we had a similar progress during the New Deal, and it seems that now with the results of globalization and this time when machines take over labor, it's due for rethinking, and we appear to be having a vibrant conversation. So the good news is this could be a time of possibility there. And Amit, I thought, had a very interesting point. He said, this crisis. He's talking as a doctor who's also an investor, and folded on 3 acts. He said the first thing was we were very shocked by what went on, had to respond. Then we were very hopeful. What a great time to bring about change, to put in new technology. He said now we're just struggling to keep up. Right. So there is this notion that we're due for a change, and it's globally kind of a reckoning. And on the other hand, there's some sense of exhaustion of how do you adjust to a new normal, right? In other words, this thing looks like it's going to stick around. You can't assume a vaccine. You can't assume that we opened up in June. So could someone explain what an equilibrium for the next 2 years might look like? So those seem to be the two things on the table.
Your comment on exhaustion, I think when you read the Splendid and the Vile, we've talked about that in other episodes, the book about Churchill, but it's actually about the diarists in England who are keeping daily diaries, the citizens, and how the BBC would tap into those diaries to actually see, because there was actually belief by mental health professionals that 300 days of bombing would turn out to be would drive people insane in Britain. And it turns out actually 200 days, 300 days, 400 days of bombing did not drive them insane. It turns out humans were pretty resilient. And this feeling of exhaustion, get over it, maybe. I think there, and even I think Susan's comment about the rise in telehealth and mental health telehealth for even the hospital workers, I thought that was actually very powerful to hear, because I think that has been often hidden away if you have a mental health problem, or hidden away, we can't talk about it. And I think actually everyone gets to feel this, but humans have grit. And they have grace, right? We heard that from one of our other visitors, Ellen, that when she sees people that are near end of life, time slows down. They have grace. They can let go. They can understand it, but they also have grit. They want to live every moment they can. And I think one thing that I never see on any of the GDP charts or any other charts is all those dimensions that actually make living worthwhile. And I think this idea of exhaustion is totally valid. By the same token, people are going to go to sleep, they're going to wake up, they're going to find a reason to go on. And And some countries and some systems have had to deal with this for decades. We're dealing with it for a few months. We have to find a way to bounce back and be resilient. I would love to see resilience be the thing that we learn, or grit, in this process.
I completely agree. I also think there's something what you said that is currently underestimated, which is the resilience you see in the economic system, because across the economy, across the world of small businesses, individuals are adapting, starting from the big companies, all the companies that have switched to remote working, but also people reinventing their businesses, restaurants learning how to survive with just a takeout service, home deliveries. People at every level of the economy are starting to, as you say, adapt, because we are extremely adaptable. We have grit. So this makes me optimistic. And also thinking of this and thinking of what Peter said earlier, let me tell you what I think is the biggest challenge we have ahead, and see what you guys think. It seems to me it's definitely true that the capitalist system we have, including globalization, is due for a rethinking and an adjustment. We have underestimated its costs, both globally and focused on specific categories of people. We've underestimated the risks. There are a number of distortions that need to be addressed. Now, however, we are doing it now in a situation where every economist, this was your initial question, Peter, every economist would now agree that for now, in this transition, in this period where we don't know what the new normal is, we don't know for how long we need to keep part of the economy frozen, there is no alternative but for the government to push money into the economy to help people, to help businesses. And, hard-nosed as I am, even I agree with this. But then this also naturally leads you to say, okay, but then the government needs to do this. The government should also invest more in infrastructure, which is true. The government should help reshape the rules of the game in this new capitalist economy that we want, which is also true. So you're pushing towards the government doing more and more, and then you take a step back and you say, just the governments we have today pretty much across the world, I don't know how much confidence they inspire to you guys, but they don't inspire me too much confidence. And instead,
although I would say this, I would say though that the confidence of the professional class versus the elected class is very different. Right. When you look at Michael Lewis's book, The Fifth Risk, he points out that there are people who show up every day that through the Republican, the Democratic, the whatever, and in other countries, I'm sure, that manage existential risk every day, and they show up and they actually are trying to do their work and they're trying to figure that out. I think the number has changed from, 1 in a trillion possibility risk to a 1 in a 10,000 or 1 in 100,000 or 1 in a million risk for some of these existential risks. And that's the current state of how governance is working. But I think you're right about the trust in that, because it's not like everybody even reads Michael Lewis's book, The Fifth Risk, or who even knows who the heck that guy is. And so I think the trust in it is at an all-time low. I do think, though, that from an economic theory standpoint, and it probably goes back to Adam Smith or goes back to Ricardo or goes back somewhere, that the idea that the classification of government, the classification of certain categories as being unproductive to the economy, as being basically servants to the productive class, the makers, the whatever, I think that needs to be reevaluated. Because any complex system you've ever found has regulatory needs. I mean, there are regulators in a system, and I don't mean regulators like government regulators. I mean just regulators like a regulator on an engine, so the engine doesn't explode and things like that. I hear
embedded in Marco's comment a question of who shall form these rules. I think when you talk about trust in government, and you made a comment earlier that Stiglitz uses Europe as an example, but Europe has greater unemployment and, presumably they're a bit more socialist. I hear embedded in what you're saying, do we trust our governments to get us out of this? The flip side would be, do we trust the pure market to get us out of it? Is it just the firms? Or or is there something else, right? We are at a redesigning moment now.
Is it only two choices? Yeah.
Thank you. Thanks, Mick.
Yeah.
No, so I think we should stay away from the two extremes. And the challenge is exactly to find the right combination of government and private sector, realizing that, to stay with US examples, government has always played an important role, not just in setting the rules of the game, but also in making sure that the institutions are solid, the culture of the country is solid, that the economy can function. The government, however, is both DARPA and NASA, as well as the DMV, so that has pockets of excellence and pockets of inefficiency that can tie you up in knots. And similarly, the private economy has been the engine of innovation, of wealth creation, but it's also the source of enormous distortions. So my concern is, can we strike the right balance between the two today, when so many institutions are fractured? So I don't see it just as an issue of public confidence making. I don't think it's just an issue of the public's confidence in policymakers. I think it's really an issue of us as a society being able to find the right balance between the public and the private side as we reformulate and we restructure the economy. And again, you see, I escaped Europe to come to the US. So my bias is I tend to be instinctively more scared by socialism because that's what I grew up with. And so instinctively, I'm worried by the fact that we're going into this restructuring in a situation where the government has to take a bigger role, because otherwise we do end up in the Great Depression. So that's why I worry about how can we get it right.
I have a final question, and it's a practical one. Back to this question of, because from the very start, you've said, let's examine all of our assumptions and try to really understand the mechanisms that are at work so we can push reopening. And you even pointed out from a systems point of view, if you know that young people are going to go out and you can't make them not do it, build that into your system. So let's just say that as an economist, you actually had a couple of clients here who actually wanted to make a decision. So we have to make a decision. And you had in the room Lenny Mendoka, who runs economic development for California, and Eric Gertler, who runs it for Governor Cuomo, New York. And here are two of the nation's largest economies, both trying to come out of something. What's the advice that you'd be giving that says, here's the questions to ask or the path of what to do over the next 3 months so we don't go down the Rubini path and we solve for what Susan said, just do it safely? How would you help guide us out of that, or at least set up the problem that perhaps we'll solve on a future show?
I would tell them, I would tell them, take a look at your economies. Take a look at the number of people who are employed in different industries, the level of economic activity generated by different industries. Then get no more than 3 medical experts and 3 economists around the table to try to discuss in each one of these industries, how can we restart activity in a way that is economically sustainable, not necessarily brilliantly profitable, but economically sustainable and reasonably safe from an infection perspective. And give every set of people, economists and epidemiologists, a small number of vetoes that they can play, where the epidemiologist, for example, will say, no, this economic activity, you're not reopening it until there is a vaccine, period. But you can say it for a few activities and not for every single one of them. And then have them write down a set of simple steps and then build a credible timeline, which you then put on the table. You give it to your businesses, the businesses in your constituencies, in your states, and you stick to it. You don't panic if you see a rise in infections, but you still have capacity in your hospitals and case fatality rates are still coming down. Treat your economic agents, your students, the people in your state like responsible adults, and maybe, just maybe, they will trust you more and they will trust the science more. So the advice I would tell them is try to do this, make it simple, make it to some extent, idiot-proof, except there is going to be some uncertainty that this is subject to, but try to then explain it clearly, get some buy-in, and show the people on the other side, the consumers, the young people, the business owners, that you will stick to it and that you are all in it together, instead of hitting them with a paternalistic attitude, which essentially says, you guys have been bad, now I'm going to lock you up again, which is what we're seeing now. That the tough part is what happens in that room with 3 economists and 3 epidemiologists of designing the rules and the timeline. But that is the advice I would give.
I like it. I think that's a good place to wrap it up.
Marco, thank you. We should reassemble perhaps a show with 3 health people and 3 economists and just get this handled for a state that we make up, or just show what this looks like. That is perhaps for a future.
Could we also bring like a rabbi and maybe?
I was going to say, don't come to me. I'm not getting in a room with 2 other economists.
All right. Thank you.
Not you, Marco. We won't do that.
Thanks, Peter. Thanks, Mick.
Thank you. This has been, this is, I think, our 31st show. We're 3 months or so into this, and 3 months or so since the last time we visited this topic. Thank you, Mickey, and thank you, everybody. This is very interesting to connect up between now and the past, and we will be back soon. Mick, I think in some of our upcoming shows, we're going to return to some of our themes of how the arts are responding and some of the cultural responses here. And we also have an interesting one coming up. We were with some of our friends in the spiritual and nonprofit communities.
Yeah, I like the upcoming episode will be on uncommon allies. And I think that'll be interesting around faith-based community, engage uncommon allies, and how might we all be learning from innovation happening in the edges that we don't pay attention to usually.
Right. And so this is, this whole thing takes place as we have an extreme close-up, as we did today, an extreme close-up on what is going on in San Antonio, or the most close-up on which firms are going out of business, and then the more macro vision of, throughout history, it just turns out that health events like this have been some of the biggest rewriters of space and the economies. And, if you go back and you study the plague, you realize that how cities divided up districts and how we approach fundamental mechanisms of the economies came out of this. And so this premise we had at the beginning, hey, there's a lot of innovation going on here. It turns out, well, this has happened before in similar events. That's what we're discovering. And I guess that's why we do quarantine. Yeah. Which is probably a good time to bring up the fact that it's 6:17 Pacific quarantine. Thanks, Mick. Thanks, Mohib. Thanks, Amit. Is
this our longest one yet? No, I don't know.
Jocelyn, Marco, on the entire team.
And Jocelyn, everybody.
Take care.
Let's get close, but not so close. You can share from a distance, we want to see each other. You'll have to stay in your quarantine space while we talk.